Uh, he's uh, he's having some previous system problems because he's having pededema.
No, no, no,
Uh,
no. See. Concising history means you should tell from the beginning what is the age of patient. Like you should see. You told so many points, right? So
yes.
see, at the end of history, what you should do is
Uh,
you should brief the history and you should analyze the history. That is the two aspects. Okay. So now first brief me the history. What are all the positive points you had from this history? You understood me, right?
the patient is elderly. He's
Hello.
sure.
Yeah, please tell.
He's having already medical issues. We had ruled out negative histories. He's a hypertensive patient. Mm, the treatment, there is past study when came to past history, he has only two problems like uh,
No. Okay, leave it. You tell me what are causes of bilateral patellar edema.
kidney diseases also causes pedal edema and heart also causes. In nephrotic syndrome also you can see, sir.
Okay. So what are the cardiac causes of patellar edema?
Cardiac pulse is 150 by 70 mg,
No, no,
sir.
no, no, no. I'm asking what are the cardiac causes for bilateral patellar edema?
Cardiac causes
What are the
valvular,
cardiovascular causes for bilateral patellar edema?
valvular diseases like aortic regurgitation, tricuspid regurgitation, and pulmonary
No, no,
hypertension.
no. Aortic regurgitation and all they won't cause bilateral patellar edema. What happens next? Like in what?
Right ventricular hypertrophy.
No, right ventricular hypertrophy is not a cause of bilateral patellar edema.
Anybody else from the attendees? Anybody can answer. You can unmute yourself and you can answer.
Heart failure,
Yeah, good. Heart failure. Okay. Yeah. Next.
liver diseases, or sorry, sir.
Yeah, liver diseases. Good. And
Um,
Deep
medications, he
breath.
has used Ayurvedic medication
no,
to make
why liver diseases cause patellar edema?
uh, because albumin synthesis disturbances and that may lead to pedal edema. Liver synthesis some enzymes and proteins which maintains series
No.
like
Yeah, just hypoalbuminemia. It causes in liver disease, patellar edema. Okay. Next. I'm asking what are the cardiac causes for patellar edema?
cardiac pulse.
Sir, can be the hypertension?
Only hypertension will not cause patellar edema.
Workload may increase on heart.
Are there any drugs which cause patellar edema?
Yes, sir.
Which drugs will cause? One commonly used drug for hypertension.
Telmisartan,
No,
amlodipine.
telmisartan would cause patellar edema. Amlodipine causes patellar edema. This
GABA.
calcium channel blocker group of drugs, amlodipine, cilnidipine, they cause patellar edema. Okay.
Yes.
Yeah. Next.
Next,
No. I am asking what are the other causes of cardiac causes of pedal edema?
Anybody else can also answer, not only the presenter. Those who can answer, anybody can else can answer. Just unmute yourself and you can answer.
Left ventricular failure, cardiomyopathies.
Okay, good. Yeah. And
congestive heart failure,
yeah, congestive heart failure and
prolonged standing, sitting may cause pedal edema.
sorry, prolonged.
Standing,
What prolonged?
standing, sir, standing or sitting.
That is okay. Prolonged standing will cause pedal edema. We are actually discussing focused specifically, right? We are discussing the causes of cardiac cause of pedal edema. So others are there is something called constrictive pericarditis, okay, which is common in India because of tuberculosis.
Yes.
So constrictive pericarditis also, it initially causes ascites and then causes pedal edema. Okay. So now what are the, so now as per your history, now go to the first page again. So your chief complaints are bilateral pedal edema since 4 weeks and breathlessness since 3 weeks. So what are the causes for this association of breathlessness and pedal edema?
Breathlessness and pedal edema, increase in heart size, which causes compression of the lung.
No, I am not talking anything about heart size. I am only asking causes of what are the associations, what are the conditions that cause both breathlessness and pedal edema? Heart failure. Okay. Heart failure is a cause. And heart failure is one cause. And can any lung disease cause like this? Lung disease?
Pulmonary edema.
Yeah, okay. So, is any lung diseases also, do you know what is cor what is cor pulmonale?
Huh?
What is cor pulmonale? The presenting person final year only, right?
Yes, sir.
Final year, like you are going to medicine, surgery, gynops, that part only, right?
Yes.
Yeah, okay, yeah. So
right side heart failure. Left side
right heart failure secondary to lung disease. So because of lung disease, they'll have breathlessness, and because of right heart failure, they'll have pedal edema. Okay, and what other conditions can cause SOB and pedal edema?
Pulmonary tuberculosis may also cause.
No, pulmonary tuberculosis, why it will cause pedal edema? It won't cause. You told previously any renal related issues, like nephrotic syndrome. So those conditions also, there will be fluid accumulation inside body, and they'll have breathlessness and pedal edema. And other causes,
liver failures like jaundice.
yeah, they'll have breathlessness because of multiple causes. Because of ascites, so they'll have abdomen, the pressure over the lungs, and that causes breathlessness, and they'll have pedal edema. Another thing is simple anemia. It should first always start with simple causes. Anemia, severe anemia causes heart failure, that causes pedal edema, and also breathlessness is also one of the cause. Okay, and someone posted in the chat, it's acute MI, cardiac tamponade. Acute MI and cardiac tamponade, they cause only as breathlessness. They won't have pedal edema. Cardiac tamponade is an acute condition where everything happens all of a sudden fluid accumulation around the lungs. Sorry, sudden fluid accumulation in the pericardial space. It compresses the heart from all the directions, and it will cause cardiac. It won't allow the filling inside the heart. That is cardiac tamponade. So they won't cause pedal edema. So for pedal edema to occur, how much extra water should be accumulated inside the body? Nearly 4 to 5 liters. Okay, so 4 to 5 liters of extra fluid should be accumulated in the extracellular compartment, and that causes usually pedal edema. Okay, so some patients in ICU patients and all, they'll be lying constantly on the bed, right? So in those patients, how will you check for pedal edema? See, suppose some heart failure patient, he's admitted to hospital. He'll be lying down constantly. You cannot check for pedal edema, right? Because all that is what is accumulated in the legs will be. Yes, good. Someone answered sacral edema, and so we should check for sacral edema in such kind of patients.
Students who want to answer can actually switch on their mics and answer. It's not a problem.
Okay, so history of presenting illness. See, don't take this case present. See, even if you are wrong, also no problem. But don't prepare something like for an exam. Okay, exam is definitely important, but what examiner actually sees is they'll see what you are analyzing. You just read history from top to bottom and starting examination. So thing is, you should analyze the history. What examiners expect is whether you are trying to find out what is the diagnosis or not. You should tell as many differential diagnoses as possible. Okay, so you told patient was apparently normal 1 month back and he noticed edema in legs. Okay, so what are the causes of sudden onset edema? So just note down all these questions and later read. Okay, so what are causes of sudden onset edema? Okay, what are causes of painful edema? And in past history, you told patient had similar complaint of pedal edema 9 months back. History of right leg cellulitis, which patient was used Ayurvedic medication, later learned debridement. Okay, so cellulitis, will it cause bilateral edema or unilateral edema?
Unilateral edema.
Unilateral edema. So how will you differentiate a cellulitis? Suppose patient having bilateral leg cellulitis. Okay, how will you differentiate whether it's a cardiac cause of pedal edema or bilateral cellulitis?
Checking for pitting edema, sir.
No, both can have pitting edema. Usually cellulitis is sometimes non-pitting, because cellulitis it's actually look tense, but cellulitis can also be pitting. What are other points?
Associated with pain, sir.
Yeah, which is associated with pain?
Cellulitis is associated with pain, sir.
Yeah, usually cellulitis edema is associated with pain, and also cellulitis is because of inflammation, right? So there will be severe inflammation, and there will be reddish discoloration of legs associated with a glossy appearance, and they will be very painful. They won't allow you to touch it. Okay, so but bilateral pedal edema, even if you touch, press, nothing will happen. Okay, so and usually cardiac cause of edema, they are pitting, but cellulitis and all, they are usually non-pitting. And yeah, what else? So from the end of this history, do you think it's a cardiac cause of pedal edema or a pulmonary cause of pedal edema?
Anyone from the audience? Just tell your opinion, okay? So most of Karthik, actually most of the students are just under the 5 years.
Okay.
Just enter here. So maybe వాళ్ళందుకే ఇంకా అంత exposure issue. But
Sure. You just tell your opinion. No, just type in the chat or else your voice is not clear.
Sir, based on the onset of history, it may be first cardiac cause, sir.
Onset of history, what only bilateral pedal edema since 4 weeks and breathlessness since 3 weeks. So you feel it's sudden onset and it's because of cardiac. Is that because of short history?
Yes, sir. Because the first one which is listed is bilateral pedal edema, sir. So when we think of the cardiac cause, sir.
Okay, and why not some nephrotic cause? Why not some renal cause?
Sure, in renal causes, we may first see the edema in the facial edema, sir.
Okay.
But the patient present with the complaint of pedal edema, so we can first look into the cardiac causes, sir.
Now, many times the patient might not note the facial edema also. Many even renal disease patients, they present with bilateral pedal edema only. Why not pulmonary? What I asked before, like breathlessness, pedal edema. What about smoking? What about, show me that personal history. Personal history, what is there? Is the patient smoker?
Yes, sir. He is a non-smoker.
So he is a non-smoker. It could be a pulmonary cause also, na?
Yes, sir.
As per your history. And why not liver problem? Patient is having alcohol consumption, 90 ml local toddy. Why not a liver disease?
Sure, he doesn't have history of jaundice, sir, or in general examination there is no interest, sir.
No, history of jaundice you can tell in past history also. History of jaundice. See, so next time remember this. Any history, after you tell history, at the end of history, you should tell all the positive points and you should concise history. It means you should tell like an 83-year gentleman who came with history of bilateral pedal edema since 4 weeks and breathlessness since 3 weeks, with history of similar complaint of pedal edema 9 months back. He is a known hypertensive on regular medication with no history of diabetes or CKD or CAD. He is a smoker and an alcoholic with no significant family and personal history. So this is the summarizing history. What I now I told is I summarized history. Next is you should analyze history. Analyze history means you should tell like patient. You should tell all the possible factors. An 83-year-old man. 83-year-old means he might be having LV dysfunction. He might be having coronary artery disease. So he might be having COPD component. So all these you should consider. And you should tell what are all the causes you think. So at the end of history, you should give some 7 to 8 causes, and after examination, you should rule out one by one. That is how you do. Uday Shankar sir, your comment.
Yeah, that is correct. Probably, what I feel is we should give our questions and answers also. The kids today are being spoon-fed. So I think మనం క్వశ్చన్ అడిగి ఆన్సర్ మనమే చెప్పేస్తే బెటర్ లాగా ఉంది ప్రస్తుతానికి, బికాస్ అంటిల్ దే గెట్ ఇన్ టు ద కంప్లీట్ క్రక్స్ ఆఫ్ ద హిస్టరీ, యాజ్ కార్తిక్ సార్ has told, Dr. Shazia, you have to summarize the history and differentials. As a UG, I think you should be able to give at least 3 or 4 differential diagnoses and some points in favor and some points against the differential diagnosis in your history concisely. I think from here we can go to the examination part, Karthik. Examination వెళ్ళిపోదాం ఇంకా టైం అయిపోతుంది.
Yeah, continue please.
షాజియా ఎగ్జామినేషన్ చెప్పేయమ్మా. డాక్టర్ షాజియా, డాక్టర్ సూర్యతేజ, check into it please.
హలో.
యా షాజియా చెప్పండి. మీరేం కంగారు పడక్కర్లేదు, ఇది చాలా చాలా క్యాజువల్ ప్రెజెంటేషన్. యూ జస్ట్ టెల్ వాట్ ఎవర్ యూ ఫీల్ లైక్. ఓకే
ఓకే సార్.
యా, సో హిస్టరీ ఈజ్ ఓవర్. జనరల్ ఎగ్జామినేషన్ వైజ్ చెప్పండి ఫస్ట్.
ఓన్లీ జనరల్ ఎగ్జామినేషన్ వైజ్ pallor, icterus, cyanosis, clubbing and lymphadenopathy are absent. Pedal edema present, bilateral pitting edema up to knees, and corneal clouding in eyes is seen.
Dr. Shazia,
Arcus and
Dr. Shazia, which year are you? Which year are you?
I just entered final year, sir.
Okay, where is the build? Where is the nourishment? A moderately built, moderate nourished, elderly gentleman. అలా చెప్పాలి కదా.
Okay, sir.
Yeah, please start that way.
Patient is conscious, coherent, cooperative, moderately built, and moderately nourished. No pallor, no icterus, no cyanosis, no clubbing. Pedal edema is present. Bilateral pitting edema up to knees. No lymphadenopathy. Corneal clouding in eyes. Arcus stenoideus in right eye. Locomotor bronchi sign. Raw area.
No, what is that locomotor?
Bronchi, sir. Sorry,
means?
Adi. Spelling super. It's locomotor bronchi. Pulsation, prominent pulsations of brachial artery.
No, what is it called?
Locomotor brachii sign.
Locomotor brachialis. It's called locomotor
Presence of-
brachialis. Okay.
Okay, sir.
Okay. Next.
Presence of prominent pulsations, sir. Brachial artery. Raw area over dorsum of right foot. Is small area is involved, 5 into 8 centimeters. Vitals are pulse 86 beats per minute. Irregular, variable fed.
No, I'm not able
In
to
all
see the screen. Screen is not visible.
Pulse, vitals pulse, 86 beats per minute. Irregular, variable felt in all peripheral pulses, no radial delay or radiofemoral delay. Heart rate is 110. Apex pulse deficit is 24.
See, next time when you are presenting, okay, fine. Pulse, BP, respiratory temperature. So you are describing pulse. Okay. Pulse is
Vessel wall.
Pulse is irregular. Huh?
No, sir. Yes, sir. Irregular.
Okay, irregular and variable. Okay, so what do you mean? What is that cause? Irregular and variable pulse means what?
Uh, de- Delay in heart conduction with my
No, see, irregular pulse means it's a atrial fibrillation. No? Irregular pulse is cause for atrial fibrillation. Okay.
okay, sir.
Yeah.
Vessel
Next.
wall thickness. Vessel
You
wall
wrote na
thickness.
apex pulse deficit. What is it? Apex pulse deficit means?
It is a difference between heart rate measured from heart sound and radial pulse.
Why is it happening?
Because of the delay in conduction abnormality.
No, not because of delayed conduction.
Sir, due to hypertension, okay?
No, anyone? What in atrial fibrillation? Why there is an apex pulse deficit? Yeah, read this today. Okay. Yeah, next. Yeah, CVS examination. No, your voice is not clear.
150 by 70 head mercury measured in patient's arm in supine position. Respiratory rate is 22 cycles per minute. Yes, sir. Inspection of neck. JVP is raised. Serious
No,
examination.
what is the importance of
Inspection of neck. JVP is raised 8 centimeters above sternal angle. Inspection of chest. Chest wall shape is. Sir,
yeah?
your voice is not.
My voice is. Am I audible?
Shazia,
No,
you
now
are having a problem. All of us can hear each other very well. నీ వాయిస్ వినిపించట్లేదమ్మా.
ఇప్పుడు వినిపిస్తుందా సార్?
Yeah, వినిపిస్తుంది చెప్పండి.
JVP is raised 8 centimeters above sternal angle, a wave arc center.
No,
Now visible
JVP. No,
thyroid.
JVP raised means what? What is JVP?
JVP raised jugular venous pulses, sir.
Okay. JVP raised means what are causes for raised JVP?
JVP. Aortic regurgitation may cause.
No, aortic regurgitation will not cause. Yeah, someone told right heart failure. Okay, good. Right heart failure is cause of raised JVP. Okay, next. What are other causes?
Increase in atrial contraction.
No, just a simple increased atrial contraction won't cause. Increased atrial contraction against some tricuspid stenosis and those conditions can raise a JVP.
Okay.
What are the
overload.
What are the waves of JVP? What are
Two
positive
waves,
waves and what are negative waves?
A, C, V, X, Y,
Yeah, which are positive
A,
waves?
which, A, C, and V are positive, sir.
Yeah, X and Y are negative waves. Okay.
Yes.
Okay. Next examination. Continue.
No visible thyroid enlargement. Inspection of chest. Chest wall shape is elliptical symmetrical. No precordial bulge. No chest wall deformities. No dilated veins or scars or sinuses. Apical impulse visible in fifth intercostal space, 2 centimeters lateral to mid-clavicular line. No visible pulsations. When come to palpation, apex beat in fifth intercostal space, 2 centimeter lateral to mid-clavicular line, and is hyperdynamic in neck character. No palpable sounds and murmurs. No parasternal heave. No palpable P2. No palpable aortic and or suprasternal or epigastric pulsations. No precordial or carotid thrill. Percussion. Upper border of liver dullness. Right border correspond to right sternal border. Left border correspond to apex beat. No dull beyond apex beat. Auscultation. Mitral area visible variable S1. Tricuspid area pansystolic murmur is high pitched soft blowing murmur of grade 3. 3 to 4 is heard with the diaphragm of stethoscope conducted to the axilla and back of the patient in the left lateral position with expiration. Pulmonary area P2 hertz split could not be appreciated. Aortic area S2 sounds as second heart sound is heard. Other systems examination. Respiratory system, normal vesicular breath sound, decreased breath sound in infraaxillary and infrascapular areas. Abdominal examination, no tenderness or no scars, only soft, non-palpable hepatomegaly. CNS, no functional neurological disorders. Provisional and differential diagnosis. Provisional diagnosis, congestive heart failure, right heart failure with pulmonary hypertension, secondary chronic thromboembolism. Differential diagnosis, acquired valvular heart diseases, aortic regurgitation with tricuspid regurgitation and pulmonary hypertension with atrial fibrillation.
Okay. Once can you explain your murmur? That murmur you told, na?
Pansystolic murmur.
You told mitral area +1. Okay. Tricuspid area, panstolic murmur, high pitched, soft blowing, grade 3/4, heard with diaphragm. Can you
Yes,
explain what is that murmur?
It is caused due to the metal regurgitation or tricuspid.
No. You told you're hearing that murmur near the tricuspid area.
It is backflow of blood.
No, backflow of blood only. Like, that is because of what? That is because of mitral regurgitation or tricuspid regurgitation.
Tricuspid regurgitation, sir.
Then if it see, I don't know where you read and wrote the description. Tricuspid regurgitation murmur, it never radiates to axilla and back, and it's not heard in left lateral position with expiration. Okay. So if it's a tricuspid regurgitation murmur, usually it's better heard with inspiration with patient lying supine, and it won't radiate to axilla and all. So you strike off that description and read it again. Next, you wrote pulmonary area P2 heard. Okay. Split could not be appreciated. If you are if you are telling split could not be appreciated, you should tell it as a S2. Okay. If you are telling it's P2, if you are telling P2 means you should tell A2 could not be heard. The split, if you are appreciating split itself means, then only you can appreciate A2 and P2. Okay.
Oh, okay, sir.
So, um, so what is your diagnosis? Final ultimate diagnosis? You told congestive heart failure.
Yes, sir.
Why congestive heart failure?
Because of pulmonary hypertension and increased load on right side of the heart, which causes the heart failure.
Umashankar sir, please comment.
ఉదయ్ చెప్పు ఏంటి కార్తిక్?
Sir, అదే సార్ మీ కామెంట్స్.
Comments, if you can explain about examination, we usually get an examination. Can you walk them to the examination part? Inspection, auscultation, percussion of the heart, and can you just walk them through that? Because we have almost 40 people who are listening. If you can just take them through that part, it will be excellent, Karthik. Karthik?
Yes sir.
Please. Just walk them to the examination. Ante. A cardiac examination, top to bottom.
Main cardiac examination, you should see the first thing is measuring the pulses. All peripheral pulses are present or not. You should check the blood pressure, whether it's what is the blood pressure in both upper and lower limb. That is missed actually in this presentation. And on inspection, whatever you told is fine, but this cardiomegaly part you should comment. You told tricuspid regurgitation, and again you told right heart border corresponds to right sternal border, which can, if it's a congestive heart failure, right atrium will be enlarged. So it won't be. Usually the right heart border will be outside the right sternal border. So again, that's a wrong finding what's written. So, and also cardiomegaly is present as per you told, fifth intercostal 2 centimeters lateral. But once again examine this patient properly. Usually, if it's a congestive heart failure with that kind of pedal edema, the apex usually shifts to sixth intercostal space. Okay, and percussion. Percussion usually not done these days. But if you are doing if suppose the patient is having any history of infective endocarditis, like fever and all, you're suspecting, you can tell that I did not percuss because patient had history of fever and I'm suspecting infective endocarditis. So infective endocarditis usually patient will not percuss. And auscultation, you should first tell about sounds, and later you should discuss murmurs. You should discuss all first heart sound, second heart sound, and either third heart sound and fourth heart sound are heard or not. All these points you should discuss. And differential diagnosis also you should tell a little more. Main thing, okay, this you people are entering final year, so it's very basic presentation for all of you. But what I suggest is you read some clinical methods book, like usually Alagappan you people will be reading, right, in MBBS.
Yes, sir.
So Alagappan or some clinical book you should read well many times. Reading one time is not enough. At least you should read some 10 times at least, that Alagappan clinical methods book. Any book, Alagappan or Golwala or all these clinical methods book. Or in Harrison, the first lesson of cardiovascular system, they'll give the examination part. You can read that one lesson many times. That's also very helpful.
Okay, sir.
Yeah, otherwise good. Try to improve this presentation.
Okay, sir.
Naresh?
Karthik, really, Asra, what is missing today? Okay, stopping at the end of the clinical history, that is really a great insight. Okay. Nowadays, students are rushing to the examination part, but at the one a good clinician stops at the a good examiner stops at the end of the history. That is what these people should learn, and really, it's a really good insight for all the students. Okay.
Main thing is at the end of history, you should analyze history and you should come to diagnosis there itself.
Yes, yes.
And then you should confirm your findings with the examination part.
By examination. Even in surgery also, it remains, in any clinical scenario, it remains the same. At the end of the history, a good examiner will ask, so what is your provisional diagnosis? So that should be learned. Okay. And apart from that, I think those who have attended, they have got a very good insight of how a case should be taken. And in due course, we will have more sessions from you, Dr. Karthik. Okay. And with a proper presentation. And
main thing is see one point I would like to add. Being students, you should be very you should have sincerity in presenting and things. You should not join from mobile or not like this. You should always be prepared with laptop with good internet connection when you are presenting with such a big platform. And other thing is you should not write in presentation what you don't know. See, you wrote apex pulse beat and you don't know mechanism. So you should only write in PowerPoint what you know. That is very important. That
what we can justify. We have to justify whatever we have written.
Yes, you write wrong also, no problem. You tell it is mild AR. Why means you should be able to justify things. And even the slides also, you should not use these kind of colors. I'm not able to see your name also properly. So the background should be somewhat dark, and it should be some, and there should not be so many lines. See, in patient medical history, you see 83-year-old male patient named Papinaidu, resident of Nirmala, came to OPD. These are all not needed. You just write only 83 years, male patient. A name doesn't matter much. Sometimes in some history it may matter, but you can write 80-year-old male patient Papinaidu, resident of Nirmala. That's all. Only two lines are enough.
Okay, sir.
Yes, Karthik. We'll improve this, especially today we had this problem with the presentation and internet. We will look into it in the next session.
Yeah. Dr. Shazia.
Yes, sir.
నీ వీడియో ఆన్ చేసుకో ఒకసారి, కెమెరా ఆన్ చేసుకో.
Okay, sir.
నువ్వు ఫైనల్ ఇయర్ అమ్మా ఇప్పుడు?
Yes.
Yeah, but for a final year, you have done very well. Probably presenting to a senior cardiologist is not a joke. You have done a wonderful job, but you can do better next time. అది గుర్తుపెట్టు.
Yes, sir.
ఈసారి చిన్న చిన్న మిస్టేక్స్ చేస్తుంటే వాటిని నోట్ చేసుకొని నెక్స్ట్ టైం ఐ రిపీట్ చేయకుండా చూసుకో. ఎందుకంటే డాక్టర్ కార్తిక్ ఇస్ నాట్ ఎ స్మాల్ బాయ్. హీ ఈస్ గోల్డ్ మెడలిస్ట్ ఫ్రమ్ అమృత ఇన్స్టిట్యూట్. అండ్ హ్యారిసన్ హీ విల్ టెల్, వెనక్కి పెడతాడు, వెనక్కి ముందు చెప్తాడు అతను. ఫస్ట్ అవన్నీ వెనక్కి హీ విల్ టెల్ యూ ఫ్రమ్ బిహైండ్ టు ఫ్రంట్. అంత అకాడమిక్ పర్సనాలిటీ కార్తిక్. ఈజ్ అ వండర్ఫుల్ డాక్టర్ ఆల్సో. Presenting to him is not a small thing. It is an extremely wonderful thing. You've done a beautiful job, but you need to practice 2 or 3 times before presenting next time. ఆ ఫ్లో వచ్చేస్తుంది నీకు. ఇంకోటి అంటే ఈ వీడియోతో మొబైల్తో కొద్దిగా డిఫికల్ట్గా ఉంది నీకు కనెక్షన్. అది నెక్స్ట్ టైం ప్రాబ్లీ ఇఫ్ యూ కెన్ హ్యాండిల్ విత్ ద ప్రాపర్ కనెక్షన్ ఇట్ విల్ బి నైస్. అది నాకు ఏమైందంటే కంటిన్యూస్గా బ్రేక్ అవుతా ఉంది. సో వీ కుడెంట్ గెట్ ద కంటిన్యూటీ ఇన్ ద ప్రెజెంటేషన్. సో వీ కుడెంట్ రియలీ మేక్ అవుట్ వాట్ ఇట్ వాస్. బట్ యూ డన్ అ వండర్ఫుల్ జాబ్. Only thing is, whatever you write on the case sheet or whatever you have in the PowerPoint, you should be substantiating it. One. Second thing, as sir told, there is a rule called 7:7. 7 lines per paper, 7 words per line. Put that call. 7 into 7.
Okay, sir.
7 words per line, 7 lines per paper or per PPT. That's all. And you elaborate on that. తర్వాత నీ ప్రెజెంటేషన్ నువ్వు బొమ్మలు పెట్టావు కదా, ఇట్ ఈస్ నైస్, డిస్క్రిప్టివ్, for a ప్లాట్ఫామ్ ప్రజెంటేషన్. అంటే ఎక్కడైనా మనం లెక్చర్ చెప్తున్నాం అనుకో, అప్పుడు బాగుంటుంది. క్లాస్లో చెప్పినప్పుడు అలాంటి బొమ్మలు పెడితే నీ స్పేస్ తగ్గిపోద్ది కదా. నీకేమో ఫాంట్ తగ్గిపోయిన సైజు, అది ఇట్ కుడ్ నాట్, ఇట్ డింట్ లుక్ గ్రేట్ ఆన్ దాట్. ఓకే, సో చిన్న చిన్న కరెక్ట్ చేసుకుని ఎక్సలెంట్ చేసాము. వెరీ గుడ్, వెరీ వెల్ డన్.
ఎస్ సార్, ఎస్ సార్. ఈవెన్ నేను షార్ట్ నోటీస్ నిన్న
వెరీ గుడ్. యాక్చువల్లీ ఇప్పుడు ఇంకా you people are presenting PowerPoints in MBBS. I started presenting PowerPoint only in my MD final year or something like that. So you people are doing good job. But thing ఏంటంటే, see, PowerPoint presentation కంటే what I understand is you should read more.
Yes.
You should, if you have something in knowledge, you can answer all the questions. So you should read at least 10 times. You discuss with your friends. This clinical cases, you before presenting on platform, you discuss with your friends. That gives actually more, that's more helpful.
Okay.
Naresh, I think from next time what we should do is presenter should
Yes, sir. ఒకసారి ప్రీ రన్, వి హావ్ టు మేక్ ఏ ప్రీ రన్ సార్. ప్రీ రన్ చేసి ఒకసారి అన్ని క్రాస్ చెక్ చేసుకొని
ఒక రన్ బాగుంటది. ఇంకా
ఎస్ సార్. యాక్చువల్లీ హాస్టల్ ఉన్న వాళ్ళకి సిగ్నల్ అవుట్ ప్రాబ్లమ్ సార్, అది కూడా ఒకసారి ఏదో ఒక సొల్యూషన్ చూస్తాను. అండ్ ఇన్సైట్స్ ఫ్రమ్ డాక్టర్ కార్తిక్, ఈవెన్ ఈ పీపీటీ, ద మోర్ వి డూ మిస్టేక్స్ వి లెర్న్ ఎ లాట్ సార్. ఇవన్నీ కూడా వెరీ ఇన్పుట్స్.
Yes.
This is a platform to make mistakes and correct ourselves.
Okay, sir. Okay, Naresh.
Thank you.
Thank you, Karthik. Thank you so much.
Okay, sir. Thank you. Bye, sir.
Yeah. Okay, Dr. Shazia, switch on చేయవే తల్లి. ఇంకోటి ఏంటంటే అమ్మా, నీ ప్రెజెంటేషన్ లో నువ్వు మైక్ నుంచి చాలా దూరంగా ఉన్నావు. సో నీ మాట వినిపించట్లేదు మా ఎవరికి. సో దట్ ఆల్సో యూ హ్యావ్ టు కరెక్ట్ నెక్స్ట్ టైం. ఓకే, బాగా చేసావు. I think Naresh, you can take the call and close the session.
Yes, sir. బాగా అయింది సార్ సెషన్ మాత్రం. చాలా మంది, I think the students they have learned a lot in today's session. అంటే అప్రోచ్ ఎలా చదవాలి ఏంటి అవన్నీ కూడా. దేవిక, can you close with mantra?
Yes, sir. Ending the session with Enama mantra. Natvaham kamaye rajyam.
Devika with Shant. Surya nada. ఒక్క నిమిషం.
Surya.
Sir, here. ఉన్నాను.
సూర్య, శాంతి మంత్రం చెప్పు.
Sir. సర్వే భవంతు సుఖినః, సర్వే సంతు నిరామయాః, సర్వే భద్రాణి పశ్యంతు, మా కశ్చిత్ దుఃఖభాగ్ భవేత్. ఓం శాంతి శాంతి శాంతి.
Thank you all.
Thank you all.
Thank you, sir.
Thank you, sir.
Thank you, sir.